Okay, people, it's 2 o'clock, so I think we're going to make a start. We know there are some people that haven't arrived yet, but I'm going to hand over to Rachel Power, our Chief Executive, just to introduce our session today.
Thank you, Lucy. First of all, thank you so much to everybody for coming and to our members for all the support that you've been showing the organisation over the last year. It's really grateful. I want to thank the staff team for all the work that went into preparing for today. We still have about 20 more people due to come, so hopefully they'll join us soon. But we are live streaming and we've asked for our first time ever, so we wanted to make sure that we start on time for people that are dialing in, because London isn't the centre of it all, and we're trying to make sure that we're open and inclusive to people from across the country. I don't have very many things to say, except that I seem to have been nominated the Fire Marshal for the day. So if you hear, good luck, if you hear that the fire alarm goes off, then follow me. I seemingly know where to go. And I do know where to go, but there is no fire alarm test this afternoon, so that's really important. We will be tweeting on the event, and our hashtag is Patients AGM if anyone wants to get online and help raise the profile, because part of the journey that we're on is to grow our membership and to grow the support for the organisation. So all we can do online would be fantastic for that as well. Toilets, I think you've all found them, but they're out by the stairs as you came up, out that way. There's tea and coffee in the back and water, so if anyone needs anything during the afternoon session, please feel free to get up and help yourselves. I think it's going to be a really exciting day. I think you've all seen a copy of the agenda, and we'll get on to the early reports from Lucy, myself, Isaac, and members of my leadership team. And then we'll do the business of an AGM, where we need to vote in some new trustees and our honorary treasurer. And then really excited to have three people with us this afternoon to help us have a discussion around improving the patient experience. And I want to also express my real gratitude to them for taking time out of very busy weeks to come and be with us, and have travelled all the way from Derby and from Leicester. So more and on for the afternoon, but please do enjoy every moment, and thank you again so much for coming.
Brilliant. So thank you, Rachel. So we're good. I'd just like to echo that. So as my name's Lucy Watson, for those of you who don't know me, and I'm the chair of the Board of Trustees. So I'm really delighted to be here at this annual general meeting. I was chair at the last annual general meeting. I think I'd been chair for about 6 months then, and to be able to be here a year later, where I hope, as we take you through and as you have a chance to look now and later at our annual review, you will see the journey that we've been on and some of the achievements. So the organisation, I think, has needed to make a lot of changes, needed to bring itself up to speed with technology, with different ways of doing things, and we're going to be able to tell you about that journey and the improvements that we've made today. So we're really pleased to see so many of you here. So the first bit, before I go into that, is just a bit of business. First of all, Rachel, do we have any apologies?
Yes. We have received 39 apologies that have appointed proxy, but we'll do that at the time of the election, and another 18 apologies.
Very good. And we have certainly from the Board of Trustees, we have 2 apologies from Simi Akhtar, who couldn't be with us today, and Archie Norton. So just 2 of our trustees weren't able to join us, but all the other trustees are here. So do take the opportunity to talk to them at the end if you've got a moment to stay on. So the next bit is to just go through the minutes of the meeting from last year for accuracy. Everybody should have a copy on the page of on their chairs to look at. So I'm only going to just, for any factual accuracy check. So first of all, page 1. Hopefully we've got titles and names right. Page 2. Page 3, page 4, and page 5. So if there's no issues, no factual accuracy, then I'm happy to sign those off as a correct record of our annual general meeting last year. And the only action that we really took forward from that as those of you who were here last year, was that we had put forward a proposal that we would amend the company's articles of association, which I'll be referring to in my presentation shortly. And that was really that we had felt that our articles had been there for a long time and didn't really reflect the nature of modern healthcare and patients particularly wanting to be active participants in their healthcare rather than being done to. So we amended the wording, which you have here, and I'll talk about in a moment. So that has been done, and those changes have been approved by the Charity Commission. And you'll now, if you look at the Charity Commission, you'll now see it it'll be seen as an amendment to our constitution. The changes to the articles, and we also made a few changes to, as you will see, as we agreed, around length of time for trustees' offices, just to tidy that up and make it a little bit more organised, so that we don't all stay on as trustees for too long and get a bit too long in the tooth. So those were all the actions. So with those then, happy to approve, and I will sign those off as a true record. So now, just have to make sure I make the technology work. So we've done that. So I'm just going to say a little bit about, as I said, about the journey we've been on and about our annual review. Can people all hear me? Would it be easier if I stood up for people at the back so then you could see me a bit better? So what I've...
Can we just ask if the mic is picking you up properly?
Oh, yes, are you hearing me all right for the live stream? Very good. Excellent. Okay. I'll stand up because I'm just a little bit little and gives me it might be a little bit easier to see me. So I've started with our vision and our mission, which I think is really important, and for the Board of Trustees particularly important that we remember what we're here for. And so our vision, which is in our current strategy, is that health and social care will be delivered in a way that meets every person's health and care needs. And I think that's a really important mission to have, that we're all individuals, we've all got different needs and we've all got different lives and different contexts to our lives, and what we want to be seeing is that health services and health professionals and care professionals are thinking much more about people as a whole and thinking much more holistically and about what is it about their lives, and as well as their illness or what's happening to them, and taking the whole into account, so that they're really agreeing a plan of care with someone that means that they're going to that takes all of those things and sees that person as the individual that they are, and their family and their friends. And then our mission is to really give effect to the patient voice, to be able to hear what people are telling us and to use that to improve people's experience. And I'll talk a little bit more about how we've tried to be more effective in that way during 2018. So here's our objective, which is the amendment we made to our articles, was to say that our overall objective, which as a board we need to be really clear on when we're making decisions around the direction of the organisation or pieces of work or decisions that need to be made, that those are going to be part of enabling us to promote the health and well-being of people in the United Kingdom by influencing the enhancement of health and social care services and assisting people to secure the most suitable care and support. So that, in a way, is the overarching objective, which our vision and mission then help us take forward. And then we have our values, and I'm going to say a bit more about this. And I've put in our values because I think it's more important than ever when what we hear about in the world of work, but particularly for us as a charity and a voluntary in the voluntary sector, there have been a number of big charities who have had real problems with how they live their values and the culture that they've created in their organisations. And I don't think that we can say we're not as big as some of those charities and it's not something that we need to worry about. We do have a staff team, we do have volunteers, and we do have our members and people who contact us. So how we are having values that are going to enable us to do that in a way that is compassionate and inclusive to the people who are working with us and contacting us is really important. So just a bit about what the sort of overarching in terms of the organisation. We've had two new members join the Board of Trustees in March 2019. So Suzanne White, who is here today, and we'll be voting her in later, I'm sure. And then Daniel Hopkin, who can't, I should have included him in apologies, who can't be with us today, but Daniel's joined us as an associate trustee, so we've got our full numbers, but when we were interviewing for trustees, we thought he had so much to offer us as well that we took him on as an associate, so he can't vote, but when we have a vacancy, he'll then be able to become a full trustee. So we've got two, and that also then, so that's a good insurance policy for us as a board of trustees as well. The overarching responsibility of the board of trustees is to be with our leadership team to set our strategic direction, and then to make sure that we're delivering on that, and to make sure that the organisation is driving forward. So that's what I'm going to talk about shortly, but that has been a key focus for the board of trustees, is making sure that's what we're doing, but also importantly making sure we're getting the right information to enable us to do that. And that's about then the governance of how we work, and making sure that the information we get, the way we make our decisions, that we are making informed and effective decisions, and we know on what basis we're doing that. So if we're talking about money, that we really understand the financial position, so that when we're making a decision around our financial plans, we're doing that from a point of evidence, and we're effective in our decision making. And the same in terms of if we are deciding on a policy position, or we need to make a decision about something that someone's asked us to do, we're doing that on the basis of having the right information, so we're making an effective decision on behalf of our members and all of you. And then I've just mentioned money, so a key focus for us has been on securing a stable financial position as an organisation. Isaac Egberiju, our treasurer, will talk about that a bit more in a moment, so I won't say more about that, but that has taken up a lot of the board's time, because if we're not financially sustainable, then we can have as many plans as we want, but we won't be able to enact them. But all I will say at this stage is that I think the position is looking hugely better than it was last year, and the work that the organisation, that the leadership team have put in to get us to the position we're in has been really fantastic. So I'm going to talk about our strategic objectives, but I just thought it was helpful for members to see that these are the kind of 4 areas in which the organisation works, really. Around our helpline, which you're going to hear about today, our policy and campaign work, so influencing the policy and campaigning, and then our projects and partnerships to really work to improve patients' experience, and overarching all of that, delivering our 3-year strategy. So these were our strategic objectives that we talked to you about last year, and that we've been working to this year. I'll talk about each of them individually now. So the first one was about how we listen to patients, and that's the board. I think a lot of the trustees have been very exercised to make sure that we really are listening to patients, and that we're hearing from a goodly amount of patients, that we're not just speaking on behalf of the few, that we're speaking on behalf of the many. And the team have done an enormous amount to improve that. The board decision this year was to free up our membership, and that has meant that people have been able to join without having to pay, and that's increased our membership hugely. We've also improved our website, making it much easier to use, and I'll show you in a moment the benefits of that and the numbers of people that are contacting us, and that's much more convenient to lots of people to be able to do that, make contact in their own time. And we've maintained our partnership with the Care Quality Commission, where when people contact us from the helpline, if there are concerns they're raising about particular services, we can share those with the Care Quality Commission, and indeed we can direct people themselves to go directly to the Care Quality Commission and share those experiences, not with the idea of beating the NHS up, but with the idea of being able to share those experiences so they can really hear what's happening to their patients and improve their services. So in terms of where we've got to in listening to patients, these are some of the numbers, and these are all in your in the annual report. There's a lovely page here which is really visual and shows you all our numbers, and I've just picked out a few of them. But and I won't talk about them all at all, but the two that I would just like to pick up with the first two, that the numbers of people that have contacted our helpline for advice in 2018, and then the numbers of people that have accessed our patient leaflets. We weren't able to see that before, and we also know that that number will have increased because it's become so much easier for people to use our website. So that's just hugely important to be able to see the progress that we're making. So in terms of securing change and improvement for patients, one of the things that we've set ourselves out to do was, when we speak to the media and to government and decision makers on a range of issues, to become the go-to organisation for patients. I don't know that we're absolutely there, but I think in terms of the numbers of contacts, the numbers of different media outlets, and the amount of times that we're quoted in different areas of the media, we can certainly see that we're on that journey now to becoming a much more authoritative voice, and people, I think, have really valued the evidence base from which we're speaking from as well. We've also adopted some formal policy positions on the areas here around the Parliamentary and Health Service Ombudsman, hospital car parking charges and use of patient data, and then this year we've continued that. And that's about making sure we've got agreed positions on some of the things that are going to be ongoing topics that we know are going to be asked about, and that supports our trustees, if they're going to be speaking to these areas, to be able to be consistent and speak with one voice and make sure that we are saying the same thing around where we're doing around that. And particularly, I think, in terms of the PHSO, I know that a lot of our members have been very concerned around under the previous administration, the really significant concerns about the Parliamentary and Health Service Ombudsman, and whether they really were acting on behalf of patients and really helping them secure really strong and robust investigations. And we have continued to work with the new administration to hold them to account. And indeed, Rachel and I think, are meeting with the Ombudsman next week to look at where they've got to in implementing their new strategy, and to look and to seek assurance on how they're involving patients and how they're really making a difference compared to where they were. So, and finally, working in partnership for change. So working with other organisations, similar organisations to ourselves, looking at where we can work together with different stakeholders to be a more effective voice, and Rachel will talk about that. And then our last strategic objective is enhancing people's ability to improve their health and care outcomes. And we do that through our helpline services, which I've already talked about. And a lot of our helplines work is around redirecting, signposting, helping people to make sense of what is a very complicated health and social care world, and where they can go to get the answers that they need or get the support they need. And what's really positive to see from some of the audit work we do now in quality assurance is that 96% of our callers would recommend the helpline to their family and friends. But interestingly, the thing that people most contact us about is how to make a complaint, whether that's through the helpline or downloading their leaflets. And that's of a real concern to the board, because it's good that people are contacting us and we're able to help them. And if you read our weekly news, you'll see stories of how we've been able to help people raise their concern, raise their complaint, and get the answers that they need to get. But what we do know is that the NHS still is an extremely unwieldy body in all its different shapes and sizes in how it responds to complaints and listens to people's concerns. And there's a huge amount to do to really get that right, and for the NHS to really start seeing what our president, Sir Robert Francis, would talk about as that golden thread and that gold dust of complaints, and how organisations can learn and improve if they're really hearing and listening to that. So we have continued to do work around that, and we're in the middle now of, we've done some work to re-look at, working with different organisations, our complaints project work, to really develop develop a toolkit that we think will enable us to work with organisations in a way that will help them really move forward. So that will continue to be an area of work for us for the coming year. So finally, in terms of what do we still want to do, so although I've talked positively about our growing membership, and I've got to say that actually we think our members are now, they were 1,029 yesterday, so they might even be 1,300 today. but that's a great place to be, but we still need to grow it further. And when you look at our membership survey, the other thing that we really need to do is to diversify our membership. So we need to be engaging with a much broader representative sample of people across the United Kingdom. So that's really a concern and an objective for the Board of Trustees and for all of us. We've developed this year, in terms of the priorities of how we deliver our strategic objectives, we agreed to focus on a single policy programme of work, and that is focused on patient experience. And we're in the middle of an engagement process around how we hear from you and from all our members on what matters what are the things that we should be really working on that would make a difference to improve experience of patients of health and care. And the other area is really demonstrating the impact of our project work. So we had lots of project work going. Some things have come to an end. And as we develop our new projects, we really want an approach that starts to set out what are the outcomes we're going to achieve for patients and how we're going to make sure that that has an impact across a broad membership and a section of the population, not just in a little area over here. So that is another key focus. So I'm now going to hand over to Isaac as our treasurer to just take you through our financial position. But everything I've said is covered in much more detail in this annual report, which I hope you will take home and enjoy. It makes excellent bedtime reading, I've been told.
You mean you haven't read it at bedtime?
I was reading slides last night instead at bedtime.
No.
That's the one slide. Hello, Flo. My name is Isaac Egberedu, has just been announced by the chair. And before I start, could I indulge by thanking my predecessor, Caroline Hewitt, who has done a fantastic job and made my job a little bit easier to do. Thank you, Caroline. Now, as you will all see, the chair has just spoken to us about what we're trying to achieve at the Patients Association. And all of this does require money. And money is very important. As she rightly said, without that money, we cannot achieve all the things that we achieve for patients, which is the most important thing to this organization. As you can see from the slide up there, our reserves at 1st of January 2018 reduced to 204,000, and that's from the 461,000. The year has been very difficult, but we keep making slow progress in the right direction. Our total income for 2018 was a bit more than what we had in 2017 at 432,000. Unfortunately, the expenditure was a bit more because things cost more. There's so much more for us to do, so much more that we love to do. However, we were comforted that we had more than sufficient reserves, as you will see, of 204, which we carried forward from 2017, and that enabled us to make a loss of £61,000. That loss compared to what we had in the previous year of 257,000 was quite a journey for us, and we really worked hard. And for that, I would like to thank our management team for doing such a fantastic job. Where are we now? Reserves at the end of that year was 142,000. As you all know, it's good to have something in your back pocket for the rainy day. And we are working so hard to make sure that what we have in our back pockets is sufficient to carry us through, so that the disruption to the services we provide is limited. The reserves that we have currently, we intend to maintain it. And going forward, this current year we are in, we are working so hard to make sure that we have a balanced budget. Once we get to a balanced budget position, we intend to build on that so that it gives us succor and comfort in terms of the reserves that we have for us to be able to deliver the services, which I'm sure our chief executive will enlighten us more about And at some point during this afternoon, Sarah, our incomes manager, will also speak to us more about it. So for my short introduction to the floor, I think it's probably sufficient for me to stop here and hope that the support that we get from members, both in terms of your donations, in your words of encouragement, will continue to spur us on to deliver that common goal which we all share for the patients. Thank you.
Thank you, Isaac. So just before I go on, so what Isaac and I have just presented then is our overall annual review, and you have a copy of our annual report and our annual accounts. So are there any questions that people would like to ask at this stage or points they'd like to raise before we go on to the... Kirit?
In terms of obviously the reserves going down, has that been lack of donations coming forward, or is that been having to be spent on projects or obviously run more staffing costs? So just give an idea of why the reserves have shut down.
I think so.
Well, do you want to
Well,
just
it's not
answer?
the staff increase. It's more due to the donations, because as you know, donations are really very difficult to come by, and you are competing, like most charities, competing for funds from funders from everywhere, and we continue to strive very hard. So it's very difficult, but the staffing is definitely not the cause of that.
There was also... Yeah, well, I was just going to add to that, there was also a conscious decision to reduce our reserves from the point at which they were 460,000, because when we were applying to trusts, they would not give us money when they saw that our reserves were too big. So we did need to reduce them, but Rachel might want to add to that.
Yeah, I think so. Sarah's presentation, which will be coming in about 10 minutes, will show the history of where the income, where the slippage in income came, and where we're growing back the income to the levels we need it to be at.
Yes.
Yeah, Fraser Simon from Streatham Hill, Simon Rose.
Very good.
Just wondering, in terms of your membership numbers, what's the critical mass you feel you need to be going forward with a lot of them?
It's a wonderful question, and that's one we have just appointed to Shivani's role, who is our community engagement person over there, and so we are just setting figures. It needs to be an awful lot bigger than what it is at this very moment in time. It needs to be in the thousands, the actual. So we're just developing a strategy for that area where we're looking to see how we can get it to, when we can get it to a figure of around 10,000 as a starting point. But up till now, the growth has been very organic, and we haven't had anyone focusing on the marketing and the development. And I'm going to talk to you about the membership survey, where you've given us some feedback on what we can do as well.
Okay.
Thank you.
Thank you. I'm going to move us on then now, because I'm just conscious of time, to our Chief Executive's report. So Rachel, over to you, and here's a little super machine.
And here's where where do I point the super machine? Oh,
There you
there.
are.
That's
There you
brilliant. Okay, thank you so much, Lucy and Isaac, thank you. And I think the journey that the organisation has been on has been one of real teamwork between the staff and trustees and membership. I need to move. Okay, thank you. So I don't get lost. So I think Lucy hit on the fact that we're getting our influence out there is becoming much bigger, and a lot of the things I'll talk about today are more things this year than last year, because we're in October, and it's just good to see where we're at and where we're going. So I think last year I was appointed as Chief Executive to the NHS Long-Term Plan Engagement Workstream, and that gave us great national coverage. And from there on, at the beginning of this year, in March of this year, I was appointed to the NHS Assembly, and the NHS Assembly is 55 individuals, not on behalf of organisations, but it's because I'm with the Chief Executive of the Patients Association is why I was appointed, and is seen as a guiding coalition to see what's happening with the long-term plan, and getting presentations from different people involved in implementing the long-term plan. So we've only had 3 meetings. It's in its forming stage and developing stage, but it's still a great place for me to be, because it means I can keep raising the patient voice and asking questions on behalf of patients. And I'm joined by a real cohort of wonderful people who are appointed as well on the basis of that they are patients or carers within the community. We're also a member of the Health for Care Coalition, and that is a campaigning group that's looking at trying to raise the profile of the need for proper social care. We're involved with Parliamentary Health PHSO in developing their complaints framework, and that is their quality toolkit that they want to look at how complaints are managed within services. We've just been appointed by the Department for Health and Social Care to help them work on their complaint strategy, which is working in partnership with what the PHSO is trying to do. We continue to be out and about raising patient voice and raising the information that we receive back from members and from non-members who complete our surveys, and have presented at NHS Expo this year and the Patient Safety Congress. So people are coming to us for our views. This is why we're coming to you, so that we can really represent patient views in everything that we do. Lucy mentioned two of our mentioned our projects, and I just wanted to point out that two of our freelance project managers are in the room, so they're around too if you want to have a chat with them about some of the work that we've been doing. So going on swiftly, Lucy talked to you very much about the external strategy that we had, but internally we had a lot of work to do and a lot of good work to do, and I'm delighted to say that 2 years into the role, 99% of the staff have stuck with us on a journey, 99.9% of staff stuck with us on a journey where we've gone from an organisation that's very, very evidence-based and really trying our best to engage properly with people externally to hear the views. But part of that was changing how we worked as well internally. We're still based in P Block in Northwick Park, and still a very small organisation, but we have worked really hard together as a team with the support of our trustees to really achieve what I do consider to be quite high performance across the board. The other internal strategic objective we had was to improve and enhance our sustainable organisation, and I know hopefully at the end of this session we can ask more questions, but I think hopefully when having heard from Isaac with a reduction of nearly 200k in a deficit in 1 year was a great achievement, and being on aim this year to break even will be fantastic because it gives us something to grow from, and Sarah will talk to you much more about that. So we decided in March 2018, like Lucy said, to make our membership free, and it was a brave decision of our trustees, and I think last year, you'll remember at our AGM, I think our Streatham team there were asking the impact it might have had on our income, and actually Sarah will cover that a little bit more in terms of income, but it didn't. What it did was it started to grow our membership because we knew that we needed that mass critical amount of members, but you're the people who can do it for us as well. To remember we're 9 people, and Siobhan talking to you and we'll be coming out asking for a lot more. But up till now we're on track to double a membership in a year without a resource focused on that, and I think that is a great achievement, and I think that's a great achievement for the members talking to each other and raising profile as well, because only together can we do this, and it is your voice that we are trying to represent, and so we just want to keep hearing from you, and we're going to find lots more ways to keep talking to you, which is why we're live streaming. Unfortunately this year we haven't managed to get the capability for them to ask us questions, but this time next year we'll have that capability, and we're learning as we go on to how we can do that. But again, it is, Elspeth is actually downstairs, I think, doing registration, and Elspeth is our volunteer who comes in every Monday morning faithfully to sort out our membership, and she sees the excitement on my face when she comes into my office with my little stack of membership forms, so I can quickly look to see where in the part of the country they're coming from, what can I find out about them in the little bit that I'm seeing in a membership form. But you know, she does a fantastic job, so somebody tell her afterwards I said she did a fantastic job, and I tell her regularly. So we did our membership survey this year, and I'm going to have to put my glasses on because this is pretty hot off the press. We've just analysed it. We couldn't get over the response rate. 274 responses, you know, it's the highest we've had. And if we go back to the beginning of this journey that we trustees and staff went on together, we only just really had to. We had a little bit more than 274, but not many. So this is like us talking to our whole membership 2 years ago. So I think to get that level of response was fantastic. Lucy talked again about, diversifying our membership. We've got a great membership, but, it's a country where health inequalities are high, and it's something that we as a patient association need to think about doing. And to do that, we've got to diversify our membership, and we've got to engage people at grassroots levels. And that, again, I'm going to go back to the Streatham question, because to do that, we need people on the ground doing it, because it is not for us to do it to people, it is for us to enable that voice to be heard. We were delighted with the geographical representation, and it made us think, because I'm going to bypass, Lucy's covered something, we've duplicated the slide, but when we looked at the geographical representation, we thought, and then we looked at the people ringing our helpline, we were thinking, it's not matching, because the people reaching our helpline are a lot more from the London and the Southwest region. So about a month ago, I had talked to trustees a while ago about launching a free phone number, but actually on the back of the membership survey and seeing that it was a really geographical spread, but actually we were much smaller in the geographics of who was contacting our helpline. So we launched a free phone helpline number a few weeks ago, because we wondered, and there is evidence that ringing a London number can actually be a barrier to a lot of people. So again, we have our helpline in the room today. We have Kevin and we have Cecilia back there. Angela's downstairs doing registration as well, I think. Yeah. So they're around, and I think it's really important for them to meet you and for you to see them, because we're not very visible when we're hidden away and people look. So the top 3 areas of concerns for our members were around areas in our recent membership survey. Is funding and sustainability of health and social care systems, the structure and how they're operated, and engagement. And the engagement comes across all aspects, from patient safety to actually the admin, to how you get into your appointments. We're hearing a lot of feedback in those areas, and John's going to speak a bit more about the single programme of work that's coming up. The key themes that came out about being a member of the Patients Association was that they valued our voice, advocacy and representation, and the independent nature of our organisation, as well as our good reputation, our ethos, and the fact that we were patient-centred. Obviously, I was delighted to see that feedback coming from the membership, because it hopes that we are meeting the needs of the membership. They did say, then we asked about areas for improvement, and they want more opportunities to influence. They want to be involved more in our surveys and our consultation work. And I think this year we've really started to do that. We've really started to talk more. The numbers coming back to some consultations is actually really helpful. I will be writing out to all our membership in the next few weeks, and myself and Sarah were talking about this morning on our way, Shivani, to give a really good overview of what the membership survey has told us. But you've also given us some food for thought in terms of why you've become members, so that we can get that critical mass of membership going, because we wanted to hear from you what was good about being a member, and what maybe is not so good about being a member, so that we can build on that and really use your stories of how you value the membership of the organisation to help us sell that story. So if anyone has any ideas, my business cards are around somewhere, so please feel free to get in touch, and I'll point you in the right direction as Shivani and myself. So I think that was the part, and the other area that the membership survey talked to us about was reaching those communities. And standing here, I hope that this time next year, well, I know that this time next year when I come back to talk to you, we will have made great strides in representing those voices that sometimes are not heard. And I hope that today is the start of that, because for me that is one of the most important things that we can be doing, where good may seem to be good enough and it's just not good enough. and we need to help hear those voices. I've got this as well, I keep forgetting what I have. So I'm going to leave the helpline because we talked about that, but we are seeing an increase in calls, and we are just developing some new patient information leaflet work, and that hopefully will increase the access to our website as well. So Shivani is our new head of programs as well. She's taken on 2 part-time jobs with us, and she took over from Heather Richardson, who'd been with the organisation for a number of years and who had done a fantastic job and retired in December of last year. And a lot of the projects I'm going to talk to you about had started under Heather's leadership and have continued. And we've really tried to structure our project work to make the greatest impact and the greatest difference to the greatest number of patients. We'll still continue to do smaller pieces of work, but on the whole our work is getting much larger. One of our greatest successes in the last few weeks, and I know this is last year, but I wanted to celebrate this here, was our care home charter, and that was a piece of work that had been going on for 2 or 3 years. And it is a 9-point charter for patients and professionals about medicines within care homes. And we were delighted at the end of that project to be able to, and Francis helped me lead on this, we have many a phone call, but we were delighted when NICE were willing to publish the guidance for us, because that will help us get the credibility for the piece of work. And I think this time next year again we'll be telling you more about that piece of work, because we're now with NHS England under their patient safety under medicines to talk to them about how can they implement the care home charter in the work that they're doing, and they're very, very positive about that. Now this is where I sometimes get a little bit confused, because I am not a doctor and I'm not a nurse. So madly, I get confused. It's the switch to biosimilars. That's right, isn't it? Yes. From biologics to biosimilars. So again, this project started quite a few months ago with us hearing that people weren't getting enough information. The patients didn't feel that they had the knowledge, or that they were being told enough about why they were being switched. And we are now at stage 3 of that project, and we are co-designing resources, and we're co-designing them between patients and professionals. What good information looks like, what really good shared decision making looks like. And we're hoping to move on, as just before we left, you're getting hot off the press here, just before I left the office we've developed a further proposal for a funder to say, because they want to see how we can pilot it now, and just to really bring that shared decision making in. And I think, I'm not going to talk too much about this, because the patient experience, people coming to speak in a few minutes time on our patient experience program are very much going to be talking to you about what good shared decision making can look like. So we'll hear from the patient voice there. We continue to do a lot of work on our complaints toolkit, and you'll know that Sir Robert with mid-staffs that we were involved there, but we are still talking to trusts and foundations about proper and good patient engagement in the management of people's concerns about their care, and how by listening properly that we can learn, and to use that as a quality measure how we learn from our complaints toolkit. And Lucy has been instrumental in that piece of work with us. So this is what happens when you're a trustee at a small organisation. You get pulled in to do quite a lot of work. So I am indebted to my trustees that they allow me. I think every one of them have been pulled in on different pieces of work to help support us so that we can get on with what we need to do and develop. But Lucy's been instrumental in helping us develop our complaints toolkit. The other piece of work that we did, and again I think there'll be hopefully some exciting news in the next few months about where we're going to take this piece of work, is a nutrition checklist that we developed with the malnutrition task force, and with Wessex Healthcare. And again, that is about empowering patients to know, and individuals, because I think the word patients involving citizens, patients and individuals, about what support they might need with nutritional needs. And we again have been spending a lot of this year in looking back over all the reports reports that we did over the last few years and really pulling them together and saying, actually, what is the next big piece of work that can have the biggest impact on patients? So that's just really giving you a flavour of the work that we've done over the last while. And again, if anyone wants any more information, you'll see quite a lot of information in our annual review for last year of the 27 engagement and improvement projects that we undertook. I think that is it from me, and I'm going to hand over to Sarah, who's going to tell you a little bit more about our fundraising and financial position. And I shall go and sit over here.
Okay. Hello everyone, I'm Sarah Riley, Head of Income Generation. I'm just going to take you through and hopefully answer some of your questions about where we are in terms of fundraising and income, where we've been and hopefully where we're going. So my post was created in the charity back in mid-2017, and you've already seen the figures for the end of 2017, which didn't paint the happiest of picture for the organisation. There had been a planned deficit, yes, but we were finding that the reserves position was too high to enable us to secure some types of funding. But unfortunately, given, I think, lack of prior investment by the charity over a number of years in diversifying income, what was happening really was that the main sources of income were falling and there wasn't really a plan in place to replace those. So the deficit at the end of 2017 was larger than it had been planned to be. So we've done a lot of work in the last nearly 2 years to try to remedy that position, and that's where my post comes in, was to look at implementing a new income generation strategy as part of the organisation's overall strategy, covering 3 years from the beginning of 2018. And so what we're looking at in the annual review is the results of the first year of that, but I can also touch on what's happened since the end of 2018 as well. A lot of the work at the outset was laying the foundations that we needed to develop a sustainable fundraising programme, and some of the basics, including, as we've already touched on, a new website that was capable of actually signing up members and taking donations, which is quite critical for a small charity, as well as implementing a new database to make sure that we're properly monitoring where our income's coming from, looking after the relationships that we have with our various supporters. We've also had to do a lot of internal work in terms of our record keeping, improving our governance around financial processes, and various other issues, for example, compliance with the new General Data Protection Regulation that came in last year, which is really, really important in terms of where we're being trusted to look after people's personal data, making sure it's used correctly, and that when we're asking people to support us, we're doing so in the correct way. We've also introduced policies around ethical fundraising and a due diligence process that governs how we choose which types of partners we will work with, and various other cash handling policies and so on that need to be in place in any charity in order to start to actively fundraise. But the 3 main targets of the income generation strategy were, as you can see, firstly to diversify our income. So historically we've been extremely reliant upon income from the pharmaceutical industry. We're hugely grateful for that, and we've done a lot of work to make sure that we have absolute clarity internally about how and when we accept those funds. They are critical to us being able to continue to do our work, but they are also governed very strictly both by us and by various codes of practice. Nevertheless, it's better for us as an organisation to aim to bring pharmaceutical contribution to under 50% of our overall income. What we expect is that we will achieve that by the end of the strategy period in 2020, and we're well on our way to that. As we've already touched on, the target is also to grow membership, so whilst that doesn't directly generate income anymore because we removed that financial barrier of people coming on board, actually what it has done is enable us to grow the number of people we're talking to, many of whom have the potential to become supporters in the future. So it's about growing the large number of people interacting with us so that long term we can develop that sustainable income. And finally, the brief target of to grow our income. So where are we at the end of 2018? We've both grown the income and reduced the expenditure, as you've already seen. So we've brought down that deficit from 257,000 to just short of 62,000 in the first year. We didn't see the loss of individual income that we thought might happen with the removal of those membership fees. What we find now is that although only around 12% of new members signing up make a donation, because we have so many more members signing up than we had before, that more than compensates for the loss of the income when we were charging membership fees. And we have also done small tests in terms of, we ran a helpline appeal last Christmas, which was sent out to hopefully all of you in a small target database, but that did also generate income for us. We've worked very hard to reframe the membership relationships that we have with our corporate partners. So rather than being a purely transactional relationship where we sort of email them once a year and say, please give us your money, we've got to know the corporate partners. We've started working with them in various different ways and engaging their staff. And what we're starting to see as well is individual members of staff coming on board as individual members as well. So we're just trying to nurture those relationships. And what we're seeing is that we are retaining those relationships year on year. And we've been successful so far in starting to bring new non-pharmaceutical companies on board. So, for example, Lee Day, the solicitors firm, joined us at the end of last year as our helpline sponsors, and that's the first time that we've worked with the legal sector, so that was really positive for us. As you can see, as well as we've touched on, we've implemented a new database and ensured that we are GDPR compliant, and we've also seen an increase in the gift aid rate because we, again, have moved from that charging membership to asking for donations. People are therefore more inclined to gift aid their donations. And briefly moving on to what won't be in your annual review because that only covers 2018, but since we're 3/4 of the way through 2019, it's worthwhile highlighting a few additional things. So with our revised forecasts that are based in reality and evidence of the relationships that we have ongoing, we expect to end the year having marginally increased the income again and marginally reduced the expenditure again. We have been slightly more successful this year with income from charitable trusts than we had been in previous years. And in fact, one of the trusts that we approached a couple of years ago who had not been inclined to support us did decide to support us this year. So we take that as a good sign for things to come as well. We're also welcoming on board more pharma and non-pharma partners, so growing the income across the board. And we are on track, we believe, to reduce to under 50% pharmaceutical income by the end of 2020. We suspect it's around the 55% mark at the end of this year, although we will be able to report properly on that after the end of December. And that's where we are.
Thank you. I'm going to ask John Kell to come and talk about policy and campaigns, and then we'll take any questions after
Could
that.
I just make one comment just on the back of Sarah's presentation there? I think Sarah talked about the different relationship with our corporate partners and that lack of transactional. And when I thanked people for coming, I didn't thank, we have 2 or 3 of our supporters, our corporate supporters in the room who've turned up today. And I think that's a sign, as I'm looking at one of them, that the relationship is very, very different now in how we try to work together with them.
Absolutely. Thank you. John.
Right, thank you. So you've already heard from Rachel about some of our work to represent the views of patients. I want to briefly give you a bit more detail about our policy and campaigns work. And when we talk about campaigning, we don't necessarily mean marching in the streets, though that has its place. But most commonly, if we want to make a difference, we can find simpler and more effective ways of achieving change. We need to be respected as an organisation by key decision makers in the government, in NHS England and elsewhere, and they need to know that when we make recommendations to them, they are serious, they're backed up by strong evidence, and they're worth listening to. And they also need to know that if they ignore our recommendations, they will be on the receiving end of strong criticism from us in public. The other thing we need to do to achieve change is make sure that the people who make decisions are hearing directly from the people who are affected by those decisions. So that means patients taking campaigning actions, talking to decision makers themselves. And our role then will be to make that possible not always to do it ourselves. And I'll talk a bit more shortly about how we're going to move to that way of doing things. But there's no shortage of challenges for us to address. It's a busy world. The NHS is in a funding crisis and a workforce crisis. Social care services in a funding crisis and a workforce crisis. The NHS is cutting back its offer to patients. That's through its local decision making and through its national decision making as well. It's undergoing a major transformation under the long-term plan, and the list goes on. So a lot of what we do is reactive. So we advise NHS England, Department of Health and Social Care and others when they ask our views. Often they will do that informally at early stages, but we'll also respond formally to consultation exercises when they take place. And when we do those things, we ask for patients' views to make sure that what we're saying is what patients are telling us. This is, I'm not going to read out all of these, but just for the record, these are consultations that we responded to in 2018. And last 2 slides, because there was quite a few. And for completeness, this is the list so far in 2019. Again, I won't go through all of those, but all the consultation responses that we make formally, they're available to read in public on our website. But this is an effective way of working. These are a few of the areas on the screen now where we achieved success in 2018. This isn't exhaustive, but in the area of restrictions on access to treatments, NHS England is pushing this very aggressively through their low-value medicines guidance and evidence-based interventions regulations. We have shown serious cause for concern from the survey data we've gathered about the impact of that on patients, and we have met with NHS England on this subject and asked them to evaluate this. We are hoping to hear more about their plans to do that this autumn, but it is certainly on their radar now. In terms of safety, the HSSIB, Healthcare Sector Safety Inspection Body, from memory, the bill to put that on a statutory footing dropped plans to make available what they're calling safe space investigation facilities for all local hospital trusts. We raised serious concerns about those proposals, and they've now been dropped. As Rachel has mentioned, PHSO is going to be improving its processes for seeking clinical advice, including giving patients much more information about the qualifications of the advisors they are using, potentially naming them in future because they're not routinely named at the moment, and allowing patients to comment on how PHSO makes those requests to those expert advisors for advice in the first place, because that's an area that patients have told us PHSO was often getting wrong. And we're working with PHSO and the Department of Health on new initiatives, as you've heard, on how the NHS deals with complaints. So all of that leaves us with only a very limited amount of capacity for doing proactive work ourselves to achieve change and improvements for patients. So although today is largely about reporting on the past year, I'm going to look ahead briefly to 2 substantial pieces of work we're developing that you've already heard a little bit about, certainly in respect of one of them. We've made a deliberate decision not to spread ourselves too thin, not to try to change everything at once, because we know we can't do that. But if we prioritise one thing in one area, we should be able to achieve change for patients in that area. So our proactive work up to the end of the current strategy period, which is the end of next year, will be focused on a single theme, and our trustees have selected for that theme the theme of patient experience. So currently we're doing the essential groundwork for that programme. We've reviewed what other organisations have done on patient experience in recent years and what initiatives the NHS undertakes, and we're also asking patients for their views. So we ran an initial online survey over the summer, so thank you to anyone here who responded to that. The next step will then be to take the themes that emerged from that survey and explore them in more detail. So there will be a more detailed survey online this autumn, and we'll aim to get as many responses to that as we can. Also do some face-to-face engagement most likely next year, publish an update on what we found, and then start to identify 1 or 2 key items within those findings where it's important to achieve change, and we know that because that's what patients have told us, and then we develop proposals for change and start taking them to the people who will be making those decisions. So next year we'll be asking patients to get involved even more, start talking to those decision makers, start taking campaigning actions, and hopefully we will secure some improvements. Finally, In the meantime, there is very likely to be a general election before the end of this year, very possibly, and if not this year, then early next year. In the 2017 election, we ran an election campaign. It's a very standard, common thing for charities to do. The opportunity to raise your issues with people who are standing to get elected as MPs obviously only comes along every so often. So this will be another opportunity for patients to get involved. We will again want as many people as possible to take actions that might involve going to speak to local candidates, for instance at hustings events, or it could be something as simple as putting a poster in your window or saying something on social media. So we're doing the planning work for this now. We aim to have it ready to launch more or less as soon as the election is called, whenever that is, touch wood. So do watch this space for that.
Thank you very much, John. So now we've had presentations from all of the leadership team that were here in 2018. So if there's any questions, I'm just going to take any questions anybody wants to ask about some of the work that the organisation has been doing. Yes.
Hi, Graham Simon of Design Brothers.
Very good.
Just wondering two things, possibly in relation to the NHS long-term plan that seemed to come to the forefront, particularly in Lambeth, is the introduction of the primary care networks, and then these, I think I call them super CCGs, might be ICSs or some kind of initials.
That's right.
Anyway, having looked at the PCN being sort of rather ham-fistedly implemented, where practices had to basically agree to associate with each other before they actually knew what they were going to be doing or how it was going to be working, it seemed to be a bit of a challenge, and we've had some impact because we're quite friendly with our practice managers to how that's going to be working, maybe. Although I believe the NHS England is supposed to be telling people very soon how it's supposed to be working after they've already defined how they're going to be grouping together. We've got the situation with regards to the mergers of the CCGs. Now, in Lambeth in particular, there seems to be some challenges in as much as the six for South East London that are going to be merging involve like King's College, which has like $500 million debt. So you've got a situation that the super CCGs are perhaps going to get less income. They have to absorb the debt that some of these foundation trusts have built up, and yet there's going to be apparently no reduction in services, maybe. And what one wonders is this just being like super ham-fisted by NHS England, or is there some ulterior motive with regards to how they're doing things? Because it seems to be so cockeyed as how they're trying to implement this stuff. They're like, look over here, oh, by the way, now you've got a super CCG. We've heard that there was no requirement for public consultation, although there is supposed to be some public engagement. And yet when it came to public engagement events, it was a case of, well, maybe we ought to be defining what engagement actually means, because you don't seem to want to talk about the mergers. So we ended up having a situation with our Lambeth CCG, and it was interesting because Adrian McLaughlin was sitting there and he said, how about producing a prospectus? And there was like a light bulb moment, like, oh, that was quite a good idea, to explain to people properly with numbers why this is going to be a good idea. So one of the things I'm wondering is the Patients Association maybe adopting and examining what this PCN and Super CCG merging thing is going to impact on people, bearing in mind it would seem to have an impact on output of services, and yet nobody seems to have particularly a clue how it's going to be working or why it's going to be working. And before you say anything, I'm actually a fan of economies of scale, so I think it could be positive, but the presentation material is just impossible to understand.
So for that, just before I ask Rachel to respond, for those of you listening to all of that, I think what you've really clearly articulated is just how complex some of these changes are, even if, as you say, there may be economies of scale in the longer term, and how difficult it is for patients to really understand how services are going to be organised and how things are going to work. So Rachel, do you want to respond around primary care networks particularly?
Yes, I think we were meant to meet with NHS England with their patient participation leads, patient engagement, public engagement leads a couple of weeks ago, and I know I'm talking with them in the next 10 days, and it is around the role of patient participation within this new PCN network, because there does seem to be a lot of guidance out there, but it's not all been pulled together from what we're hearing. I don't know, John, if you've anything else you want to say on the overarching CCG, super CCG, but I think if you were talking about some sort of prospectus that you feel, guide to how patients can find their way around these new systems, it'd be good to talk to you more about that, so I can bring that into that meeting. Unless there's something else.
There's a lot there. First thing to say is that NHS transformation has been, the NHS is always being transformed, but this particular transformation agenda, it stretches back to the 5-year full review. It's been going on since Simon Stevens was involved as the Chief Executive. The refrain that has run through everything we have said to NHS England about this is the principle of this looks quite sensible, but what you need to be engaging patients better locally, engaging local communities better, because there is a big danger that this will be set up in a way that seems to suit the system locally on paper, but doesn't respond to what patients and communities need. We will keep saying that at meetings like the one Rachel has got coming up. They have been the track record of success on that has been very mixed. Some localities have done it quite well, some not. An organisation our size, we don't unfortunately have the resource to monitor all the localities, so we hear odds and ends of what's happening. The context in terms of that larger CCG patch, that merged CCG patch that's being created, is of course that the NHS is hugely struggling financially. Simon Stevens' metaphor once was that you shouldn't just combine the contents of two leaky buckets, because that all that gives you is one big leaky bucket. But unfortunately, that is effectively what the NHS is trying to do.
So I think the overall message, thank you, John, that's really helpful, and to Rachel, but the overall message is, and the thing that exercises the Board of Trustees most, is that each thing that you look at, I think our sense is that the NHS still doesn't do engagement well, doesn't always think about when it needs to engage, despite the numbers, that the legislation and the legal duties that are there that require them to do that. And when they do it, they often don't do it very well. So some of the national forums that Rachel is able to get into helps us try and influence that. But the more information we have from you locally about how it's impacting on you gives us the evidence to really make that case really clearly. So thank you for that. Any other questions before I move this on? Yes.
So I'm speaking on behalf of this lady here. My name is Angela. This is Lynn.
Hello, Lynn.
So the PowerPoint of the Chief Executive said that there was a broad membership at the moment across England. But the articles of the association talk about people being representative from the United Kingdom. So is there a membership
Yes.
in the UK, Wales,
Yes.
Scotland, or Northern
Yes.
So
And I probably should have said United Kingdom. And actually, one member from Europe as well, but United Kingdom at the moment.
But certainly, I think that we know, as Rachel said in her presentation, that we need to get more members from across the country, across all of the countries of the United Kingdom, to make sure that we are fully representative, and also more representative of the diversity of our population. So that is a key area of work for us this year, and will continue to be. Okay, I'm going to move this on because I'm conscious that is there somebody else wanting to speak? Sorry, I can't see. Oh, hello. Sorry, I missed your arm. Please.
Two questions actually. One on recruitment of members, and the other one is a policy.
Okay. Carry on.
I mean, you mentioned success that you've achieved in recruiting a lot of members, and I just wondered whether the name Patients Association, whether some members weren't put off by that, because when you think of patients, you think of someone in hospital.
Yes.
I just wondered whether you had any thoughts about changing your name at any point, or whether you felt that it didn't bother the members either way. What name you had.
So, we haven't yet, but you make some valid point about that, and that is something that I think we do always talk about, that the term patient automatically somehow moves people into a passive mode. But we are going to be, as I said, developing our new 3-year strategy, and there's everything to come into the melting pot. So that's a really useful point to make, and we will take that into our new strategy. And when we come out and consult you about what we should be thinking about, please remind us and bring us forward more ideas.
Yeah, and
What organisation uses what health users?
Yes.
yeah.
People consume.
And I think as we move towards our single programme of work, that term patient will come up through some of the work that we're doing, and in all the forums and in the NHS Assembly as well. It is, everyone has different terminology, but people will say, well, we're citizens, we're service users, we're healthcare users, and we try to just make sure we stick, but rebranding at this moment in time isn't going to be. The name is very strong, but it's how we market the membership with that name, which is really important.
And did you have a second question?
The second question is that about a year ago I joined my local PPG.
Good.
And I
Patient
also-
participation group for anyone. Carry on.
Patient participation group. And I've also been having meetings with a number of other PPGs in my area. And I get the impression that the PPGs are having a very hard time working effectively within the organisation, within the practice. And I just wondered whether your organisation had any more plans. I know you've done some work before with PPGs, but I wondered whether you had any more plans in working with PPGs to making them much more effective. I mean, I can give you a lot of feedback as to why I think they're not being
Yes,
effective.
that would be.
I would love to hear from you outside this meeting, and maybe we can catch up on the phone or something. But yes, we most definitely have plans to do more with PPGs, and part of the primary care network is around that PPG engagement in bigger services. So there is a range of different charities who have in the past done work about around patient participation groups, and we are all going to meet in the next few weeks to actually see again stronger together, rather than one of us going off. And we're updating our pack on patient participation, but I want to talk with those other groups to see how we can do this better together.
Okay. One last question, and then we need to move on.
Fraser Syme of Syme Bros. could I ask the audience with a show of hands, as to how many people are actually members of their patient participation group at their own practices?
Can somebody count? Elspeth, can you count how many people said yes? Be interesting.
That's very good. We will record. Well, that's a very interesting question, and it's a very interesting.
Was that about 50%?
Yeah,
I would have said
easily.
so. Yes,
I think
I
a
would
bit
have said so.
higher, yeah.
Yes, good. Okay.
Brilliant.
So I'm going to draw this bit of our discussion to our close, because we've got more discussion to come, and I want to give plenty of time to that. So that brings us on now to our voting, and the first member we need to vote for is for our treasurer. So as Isaac said, and I remissly forgot to say in my presentation, that Caroline Hewitt was our treasurer until June this year, did an absolutely fabulous job, for which I thank her enormously, and as Isaac said, she left us in a very good position. But we therefore, our constitution requires our members to elect and vote Isaac in as our new treasurer. So first of all, I need to know but just turn to Rachel to tell us about our proxy votes. We have.
Okay, so we received 39 proxy votes, of which 37 of them delegated their proxy vote to the chair. One delegated their proxy vote to Suzanne, who gets to have 2 hands in this. You can put 2 hands up if you want to, or 2 hands down. And the other gave their proxy vote to Dave Taylor. Again, you can put 2 hands up or 2 hands down.
Okay.
And can I just point out, so we do have some corporate members in the room who don't have a vote when it comes to the these elections.
The trustees.
So it's just individual membership. So if your hands can just go up when Lucy does this.
Yes. So can I ask if people, for hands in support of voting for Isaac as our treasurer? And I will add my 37 to that. So thank you. So Isaac, you are formally voted in as our treasurer. Then no turning back now. And then we need to re-elect Dave Taylor. Dave, do you want to just stand up and show yourself? So Dave is also our vice chair and has been a trustee for probably a bit more than 3 years now. And we need to re-select him for his third year term as a trustee. So can I have a show of hands to vote Dave back as a member and he's also our IT lead as trustee, and I will add my 37 votes to that. Thank you very much. So Dave continues with us. And then finally, we need to vote for Suzanne, who joined us in March as a new trustee to the Board of Trustees. And Suzanne comes with a background as a solicitor and a legal background, which we were particularly looking for to have that expertise around the board. So can I ask you all to, if people were prepared to vote Suzanne in place, and you can put up one hand, Suzanne, for your proxy vote to vote for yourself. Thank you all very much. So that formally elects Suzanne to the Board of Trustees and brings to end the voting for this year's meeting. And I will just turn to Rachel to
appointment of auditors.
Appointment of auditors, exactly.
Yeah.
And then we can coming to the end of this section.
So you'll see our annual report, which you've all had a copy of, our annual review. Who are what's the name? I haven't got the name written down. McIntyre Hudson. And just want a vote to say that we've used them now for 2 years. We found them very successful in terms of the way they work with us and very efficient. And we undertook a tender a couple of years ago when Caroline was treasurer to make sure that we were getting the best value and best service for the organisation. So we want to use them again this year to do our independent examination.
And worth saying that they have been each year to the Board of Trustees to present their examination as well, which is extremely helpful that they come and talk us through how they've reached their conclusions. So can I ask for a show of hands that we support the appointment of McIntyre Hudson as auditors? Thank you very much, and I add my 37 votes to that.
Okay.
And then finally, we need to approve the annual report, which you have a copy of in front of you, and the annual accounts. So the annual report is a fuller detailed report that's supported by the annual review, and the annual accounts are the summary that Isaac gave you earlier. So can I ask for a show of hands to approve our annual report and accounts? Thank you all very much. Now, that brings us to the end of the business part of our meeting. I'm anxious to now move on to our panel discussion and to ask Kirit and Cyriline to come and join us. While people and
Yvonne's here.
and
See Yvonne.
I didn't see Yvonne creep in, and Yvonne Coghill to come and join us, and we'll have some introductions. But if anybody would, so please come and move yourselves up to the front. But while we're doing that, if anybody wants to get themselves another drink of water or a drink, please do, and please continue to fill up and help yourselves. And while people are settling down, I'll also say that the toilets are out through the door. So if you need a few minutes just to go and have a comfort break, then please do, and we'll just regroup and get ourselves organised. Yes, comfort breaks. Please do. So straight through. because I'm just conscious of time, and I know people are going to really want to hear from our three panel members who've come to join us. So if I could just hustle you all a bit. Well, who wants to go first? You want to be last? Okay, so Yvonne, Cyril said she'd like to go last. So if you go first, then we'll go to Yvonne, and then to Cyril, and then we'll have, and then questions. Okay? That's fine. And I'm take their seats again, please. Order! Treasurer needs to sit down. Thank you. So carry on getting drinks, but I think we are going to start because I want us to have as much time to hear from the people who've joined us for our discussion around patient experience as possible, because this is one of the most interesting. It's really interesting for you to hear about, and important for you to hear about the work of the organisation, but this is also extremely interesting and will be helpful to us in our further work too. So we're really delighted to have with us our three panellists, and they're going to introduce themselves as they talk to you about what they have got to say. But really, we have Kirit Mistry, who is here to talk about his experiences as a patient and also how he's used that to try and inform his change his local services. And we have Yvonne Coghill, who is Director of Workforce Race Equality and a registered nurse and has worked in the health service for probably more years than she wishes to remember, but will talk to us from that perspective, which will also be very helpful. And then we have Cyriline, I've forgotten your surname already. Cullen. I just wanted to make sure I get it right. Who is a carer of her son and is going to talk to us about her experiences from that perspective. And then we'll have, so they'll say a little bit about their experiences and who they are, and then we've got open for questions and discussion, which I'm sure will be really rich. And Kirit is going to start us off. So thank you, Kirit.
Right, well, thank you for the invitation to speak here today and share my experiences. I'm going to start off with my role as a patient. So in 2010, I was diagnosed with type 2 diabetes, but I've had 30 odd years prior to that of caring for my mother, who was a mentally independent diabetic. Used to go to all her appointments because of language. She didn't speak English, so I knew about diabetes. When I got it, it was a bit of a shock because I should have known better, and also it was a denial for a few years. But then once I decided that in Leicester, I was shocked to see in Leicester with the South Asian population particularly, who are diabetic, there was no culturally sensitive service or support available. So that kind of prompted me to kind of get more involved with national bodies like Diabetes UK and with my local NHS structure. And as a result, we created a set of a South Asian diabetes support group. So that's currently still going on. But it was really to get us as patients to look at how we manage our diabetes, how we look at making sure we're in a position to negotiate with our GP in terms of the medication that they want to give us. So we were trying to get our patients to be more, support them, but also to look at how they can negotiate and look at what their options are. As I said, that was my patient journey. Secondly, it was more of from the social care aspect. My father was his carer, and again, due to language barriers, I used to go to all of his appointments. But he and my mother were both diabetic. My father had a heart condition as well. But the importance of going to their appointments was ensuring that they get the right sort of services, they get the right interpretation from somebody who's not just a professional, who's going to interpret on their behalf of what they perceive their needs are, but for me as a family member who know what their needs are, who live with them on a day-to-day basis, and getting the healthcare professionals to understand that I've come from a healthcare background, so you can't throw me off and you can't throw my parents off. So that was important to ensure that I represented them, advocated them at their appointments. But the light bulb changed for me because about 6 years ago, I was seeing, probably Yvonne will correct me, but the Snowy White Peaks report was launched by Mr. Klein, and around, looking at the lack of diversity of NHS workforce from a BAME perspective. But then I was seeing that from a patient point of view as well as a Snowy White Peak, because when we look at the patient structures, the NHS structures nationally, the locally and regionally, they were also not very diverse, lacked engagement. So as a patient, I thought, hold on, this is my opportunity. I saw, the first structure I saw was our local CCG, and said, where's your diabetes patient representation? Oh, Kirit, we don't have one. We do, sorry, we have a Diabetes UK representation. But I said, look, we've got a high South Asian diabetic population. I think we should add value to being on your CCG patient pathway group. So luckily they said, yes, Kirit, please come along. And so that's continued, and I continue to try and be there as a patient voice to influence how the CCG diabetes pathways. Secondly, from a regional perspective, we have the Academic Health Science Network, and they had the East Midlands Patient Public Involvement Senate. 3 years ago, when I looked at their website, saw that particular structure was 14 members of patient, public and carers across the region. Again, sorry to say, but all white, non-diverse. And I thought, okay, well then I said, well, how are you recruiting? How are you sharing this information? How are you kind of offering these opportunities? So they said, Kirit, we don't get people applying, and I've seen this same argument I've had with NHS England patient public team as well, in terms of they're saying people are not applying for these roles. So I said, well, what should we do? Let's look at how we create these workshops, how do we create opportunities? So luckily, I applied to be a member of the East Midlands Patient Public Involvement Senate, got on as a patient rep for representing Leicestershire. Then within 7-8 months, I was managed to kind of become the co-chair of that Patient Public Involvement Senate. But the first challenge was to look at how do we ensure we make this structure, this Patient Public Involvement Senate, diverse. So we then started to look at, when we were recruiting, how we recruit. Because I came from Derbyshire in terms of my work, because of I live in Leicester, I had a lot of the networks. So it was useful to tap into religious networks, patient networks, and the voluntary sector. It was very important to do that. So that's kind of how we've managed to now, that Patient Public Involvement Senate is probably about 50-50 in terms of its representation from a diverse point of view. We've also been quite active in terms of a lot of these structures now come to us. When the CCGs and the ICSs, you were calling it, and before that the transformation partnerships, they were putting their plans together but lacked community engagement involvement. So we said, here's your opportunity, come and share your plans with us, our Senate, we'll critique them, and we'll actually then give you opportunities to look at how you can get better public patient involvement in your localities, because there was 14 of us representing the region. And luckily, that as I said, we're getting more of the structures coming to us on a Senate point of view. But it's easy to, it's clear. There is still a lot of tick boxing going on. There's still a lot of tokenism, and there's a lack of, we've just mentioned primary care networks, right? I co-chair, I'm a chair of, my PPG. We're now going to be part of 5 as part of the primary care networks. But again, there's been very little engagement. What I found, my tips to some of you today is go on to, before you have dialogue with your CCG or your commissioners or whoever you want to kind of have this dialogue around patient public involvement, is firstly, we've produced some good tips on what good public patient involvement looks like from our Senate. So the Academic Health Science Network, again, I'll share that link with Shivani and she can share that. But also NHS England, through their board meetings, this was at the public patient dashboard for this September, right? Some useful information. So what I do is, when you don't get information locally, you go on with already national information that, and that's what I found, that sometimes you're not going to be liked for challenging various organisations, structures or individuals, but it's because of that challenging, because we're passionate patients, not getting our voice. So that's why we've taken the extra mile to go on with documents, go on with policies, use the acts that we, and then you'll get the outcomes. So thank you very much.
Thank you. Fantastic, and I'm sure there's going to be lots of questions, but I'm going to, we're going to open up to questions shortly. I'm going to go on to Yvonne, who I think the order of play we've chosen has worked very well to talk from her point of view.
Thank you, and we didn't even have a discussion beforehand. So thank you very much for inviting me. My name is Yvonne Coghill, and I am first and foremost a nurse. I've been a nurse in the NHS for 42 years, and I've worked in the NHS for 42 years. So I am a general nurse, I'm a health visitor, and I'm a mental health nurse by background. As it stands at the moment, I am the Workforce Race Equality Standard Director in the NHS. And it's a long story, but the issue is, and Kirit was absolutely right, that we have 1.4 million people working in our NHS, and 20% of them happen to come from black and minority ethnic backgrounds. 46% of our doctors are from black and minority ethnic backgrounds, and 21% of our nurses. In London, there isn't an organisation that has less than 35% of its staff working who are from black and minority ethnic backgrounds. So the question then is, well, why is that important? And it's important because we have lots of evidence now and lots of information about the fact that if you have a well-engaged, well-valued, well-appreciated workforce, it is better for patients. Patients have better outcomes, they have a more satisfying service from the staff, and they have a safer service. So the link between staff engagement, staff feeling respected, staff feeling that they are part of something called our NHS, regardless of their background, is really important to make sure that all of our patients, whoever they are, wherever they're from, have high quality patient care, patient safety and patient satisfaction. So, as I said, I've been in the NHS a very, very long time, and we have done and had many initiatives trying to redress the balance in terms of the numbers of senior leaders we have from a variety of backgrounds, and the numbers compared to the numbers of people we have working in our NHS. And as we sit here today in 2019, we have 10 executive directors of nursing from a black and minority ethnic background. We have 8 chief executives from a black and ethnic minority background. We have 9 chairs of provider organisations from black and ethnic minority backgrounds. So the question then you have to ask yourself is this: do we have black and ethnic minority people in our NHS who are incompetent and not able to perform at the very highest levels? Or do we have a system that actually systematically discriminates against people who come from different backgrounds, giving us perfectly and exactly what we've got? So back in 2015, it was 2014 that Roger Klein wrote his Snowy White Peeps. But there was 3 or 4 things happened at the same time as that report. Simon Stevens, who was the chief executive of the NHS, came back from America. He had been working in an organisation there, and his first appointment was a meeting at the King's Fund. And he was looking out on an audience like this, having come in from Oxford Circus. So he got on the train at the Elephant Castle, excuse me, and came to the King's Fund. And what he saw was a variety of people, a variety of faces walking through the streets of London, and so on. When he got into the meeting, the senior leaders in London all looked like him. And he said to himself, how can it be that I have senior leaders that are not diverse when actually we have a very diverse population out there? And if we have all the same people coming from the same place, making all the same decisions, we're not going to get what we need for our very diverse populations, which is becoming increasingly diverse. So from that perspective, the Workforce Race Equality Standard was born. And I'm really interested in it in my position and in my place as the Deputy President of the Royal College of Nursing, because nursing is incredibly dear to my heart, and what we know is that we have 44,000 nursing vacancies in our NHS at the moment. And the work that I've been doing shows very clearly that nurses from black and ethnic minority backgrounds will leave and go and work in agencies because they feel that they're not being treated as well. Hence, adding to the fact that we are paying lots of money to agencies when we could, in fact, be having have the staff employed in our organisations, which would be cheaper and better for our organisations all the way around. So there's something about the organisation called the NHS becoming much more inclusive in the way that it treats its staff, so that we get higher quality patient care, patient safety and patient satisfaction for all of our populations. And if we don't do that, and we don't do that well, it means that in 10 years, at the end of the long-term plan, we're not going to actually reach our objectives. And I think, on that note, I'll shut up.
Thank you, Yvonne. And that, again, hugely helpful and hugely interesting. And the relationship between our workforce and high quality care and experience for our patients,
Yes.
and being and an inclusive experience for our patients is so critical. So before we get on to questions, which I know we're all dying for, I'm going to turn to Cyril, who's also going to talk to us.
Yeah, I'm going
And
to
I think
stand
you've
up.
got
some
a couple
pictures.
Of, some
yeah.
pictures. Good.
So although this is called my story, it's not really my story, it's my son's story, it's Fergus's story. And I'm hoping to highlight how for all patients, having choice and control and flexibility is at the heart of everything and gives you good quality of life. So Fergus's story started 24 years ago, this week in fact. Like any parents, we were thrilled and excited about the birth of our firstborn son, first child, and we called him Fergus. But 16 days later, my sister Leslie died during a seizure in the middle of the night. She was 19 years old, she had epilepsy, and many members of our family had had epilepsy, but nobody told us you could die. We didn't know there were different epilepsy syndromes, and we didn't know all of the risks. So, in contact with the charity SUDAP, we were put in contact with King's College in London, the hospital, who was doing some genetic research. And we took part in that research, and we were able to help prove a genetic link to epilepsy. And we found the SCN1A gene was prevalent in our family. And we found subsequently that there are over 100 different genes linked to epilepsy now, and there are over 40 different epilepsy syndromes. And genetic research is helping doctors and consultants to identify appropriate treatment for patients. So this is really important. And this is Fergus, and he went on to have a diagnosis of Lennox-Gastaut syndrome. 6 months after my sister died, he had his first seizure. We thought it was febrile convulsions, and he had numerous different types of seizures. He had hundreds of seizures in a year, and he developed an intellectual disability around the ages of 7, 8, 9. Up to then, he was perfectly normal, bright little boy. He also developed challenging behaviours, so it wasn't unusual to find either a row of police cars or a row of ambulances outside our house. But Fergus has an education, health and care plan. He can learn, he can make progress, but it's slow progress. We had 2 other girls, and sadly for them, they also have the SCN1A genetic mutation, and they also had seizures and Jeff's plus, but they grew out of their seizures. Fergus had social care support through a short breaks programme, and that really helped him to live a normal life, to access scouts in his local village community, to go swimming, go to football. And in 2009, our family took part in the Personal Health Budgets pilot. And this was life-changing for Fergus, because a lot of children with very complex needs go to residential schools, and they get very good care and very good education, and it is what many of them require. So I'm not saying anything against residential special schools, but for us, we wanted Fergus to attend as a day student and to have that care wrapped around our family and to live as normal a life as possible. So instead of him staying at school, he lived at home, and we had care and support within our home. And instead of him going to respite, we had carers with us as a family. So he came on holiday and we had care support on holiday. It was a wraparound, inclusive, person-centred approach. And it really, really was transforming for us as a family. So as Fergus grew up, he was preparing for adulthood. He went to a special needs school, he went to a special needs college, and he graduated last summer. And this year he's starting an internship programme because he has ambitions to work. He really wants to work. And we want him to help him find his place in society. He won't be a brain surgeon and he won't work 9 to 5. He won't be able for any of that. But he will be able to find some work, some place that's meaningful for him. And we think that will give him dignity and respect and is very important to his well-being. Life has its challenges. Fergus has just come out of 3 weeks in hospital where he had pneumonia. He's regular hospital visits. He has, you'll see a VNS implanted there. That's his 3rd VNS that helps his seizures. He also has had admissions for other cases of pneumonia, for broken bones, for lung seizures, for seizures not recovering as normal. But at the centre of everything for Fergus is a personalised care approach. It's about what matters to him, not what is the matter with him. And this has completely changed everything for Fergus. And it helps him to live a normal life and be an included, important member of his village and of his local community. So this is a better slide. This is a more fun slide. This highlights the outcomes that Fergus achieves. He loves to walk locally. He loves to live with his family, with his sisters, with his parents. He loves to walk in the village community. He loves to travel. He loves swimming. He loves going to football. He is a passionate Derby County supporter. And he loves to let off some steam and listen to and support his team. He travels. He loves going out. He has a good quality life. And this slide finally highlights how the shift in relationship has changed things for parents, for patients and for Fergus, for all patients. It's about having choice and control and flexibility. And it is that shift in the relationship between healthcare workers and patients that helps everybody to have their best possible life.
Cyriline, thank you very much. That was also absolutely so interesting and very moving as well to hear about Fergus's story and the story of your family. So I've got loads of questions, but I'm going to contain myself and ask everybody here. So yes, you sir, could you just say your name as you start?
My name is Jusita Pereira.
Thank you.
The last speaker was inspiring.
Thank you.
But I want to ask a very delicate question. How do costs compare between personalized care and care in a whole?
So I'm just going to repeat the questions for our live streaming. So this gentleman was asking how that Cyriline's story was very moving, but how do the costs of personalised care, so a personal health budget, compare with care in a home?
Yeah, I can answer that. Fergus has an integrated budget, so it's 50-50 health and social care. And the cost savings, we've just worked it out this week, is 50%. It's a 50% saving in Fergus's individual case. But across the board, it's proven that personalised care generally offers a 17% saving across the whole population. But Fergus is at that top of the pyramid of complex needs. So for him, versus living in residential care with one-to-one support at all times, which is what he needs, he is a 50% saving.
Thank you very much.
And
You become even more impressive.
Thank you, sir. Any more questions? Suzanne.
Well, I thought your talk was very interesting, and I know recently that, but I know there's an impact on particularly maternal health, and black women have a much worse outcome in birth than actually white women, and I just wondered the impact of having ethnic minorities as staff and how that will then translate into improved care for ethnic minorities. minorities.
Yeah.
So I'll just say that once more for the live streaming. So Suzanne White, one of our trustees, has asked, said it to Yvonne that her talk was very interesting and that Suzanne is aware of the current interest in the fact that women from black and minority ethnic backgrounds have much higher stillbirth rates and poorer outcomes from maternity care, and if there are better representation and better involvement of black and minority ethnic staff, will that make a difference?
What I always say to people is that, you know, the staff that work in the NHS are the people that live in our society. So your black and ethnic minority staff that are working in the organisations also experience what's going on in our society. I only have a few minutes, so I can't go into it in depth and detail, but what we know, and we have evidence to show this, is that the more melanin you have in your skin, the worse your experience will be across the board, in health, in wealth, in education, across the board in your life. You will have a worse experience than people with no melanin in their skin, white people. So what it means is that you experience much more negativism in your life than your white counterparts. And a woman called Arlene Geronimus, a sociologist in America, did a lot of work on biological weathering. And what she showed was that as a consequence of these, and you might have heard them called microaggressions or microassaults, that people from different ethnic backgrounds experience on a day-to-day basis, not being able to get the food that you need to eat, people asking you questions like, where do you come from, or go back to where you come from, those kinds of things impact on you physiologically as well as mentally, and that will cause your physiological problems, which is why we have now discovered that you are more likely as a black woman or an ethnic minority woman to experience postnatal deaths of your baby and actually maternal deaths yourself. When all things have been taken into consideration, the one thing that is different is the experiences that you have as a black and ethnic minority person living in a world that has been designed specifically for the 10% people with no melanin in their skin. It impacts on you as an individual physiologically and psychologically. So whatever happens out there to patients happens for our staff as well. So our staff are probably going through similar situations. And the question was about whether or not it would improve the health of our patients. What we know, all things being equal, if you have a white receptionist and a black and ethnic minority receptionist, and a black and ethnic minority patient comes into the hospital or the outpatients, they will go towards the person that looks like them. That's just how it works. If that person isn't there, then they will make do with the person who is there. So having people that look like yourself, who can help you, support you from a cultural perspective, from a religious perspective, has got to be better for people's mental and their physical health.
Great answer, thanks.
Thank you.
You're very welcome.
Thank you. Thank you. Does anybody else have a question? Fiona.
Hello, I'd just like to say thank you to you all for some really food for thought across the board. I have so many questions, but I'm just going to restrict it to one, which is, Cyrillene, I was really interested to hear your points around how you've been able to, how Fergus has been able to understand what matters to him, and how that's been how staff have listened to you, and how you as a family and Fergus have communicated that to staff. And I just wondered if you were able to kind of give us some hints and tips as to how best people can listen to find out what matters in a person's life.
I think the key point is just ask somebody and to actually ask the question, what matters to you? It's in the slides here. It's one of the key shifts in relationship, is asking any patient what matters to them, whether it's somebody with diabetes and who has to face treatment, or whether it's somebody with very complex epilepsy, or whether it's somebody who needs to have an operation. It's the impact, having those good discussions, those conversations, those good quality conversations, and knowing what matters to the person can often filter out a lot of response and how you respond to that individual. So for example, a lot of people go to their GP with symptoms, but it might be because they're lonely, and you'll not cure the loneliness unless you get to the root of the problem. You may treat the symptoms, but you won't cure the problem unless you really find out what is at the heart of the matter. And our approach has always been to ask Fergus what matters to him, and we advocate very strongly on his behalf because he finds it difficult to communicate. He can, and he can express his wishes, but he doesn't always understand the implications of things. So when he's having an operation for his VNS or when he's in hospital, it can be a really difficult time for him, and somebody has to be there to help him through that at all times. So we do that. But I think ask the question. That's at the heart of the matter.
And Cyril, can I just follow that up with, when you talk about that shift in the relationship for you and Fergus with his health and care professionals, what enabled you to make that shift with them? How did you get them to start thinking about asking that question rather than saying, have you been on your epilim this month?
Yeah. Actually, for me as an individual, it was years and years ago when I was at work, somebody asked me to think what really mattered to me in my working life. It was nothing to do with health. It was about what does good look like for me? What does a good working day look like? And actually having a bit of flexibility was what was important to me because I could spend time with my children and my family. But it's something I ask a lot of other parents to think about. What are your ambitions for your child? Think big. Think, what would I do if I won the lottery? What would good look like? And actually you find it's often the really small things. It's that going with your dog, walk across the fields after the weekend, or it's supporting your football team for Fergus. It's living with his family, not living in care, not in supported living. That's important to him. But actually sometimes it's those simple things, those day-to-day experiences. And so it was, for me, the moment was always think what is the best possible solution if money was no issue, and then work backwards, because money is an issue and there are always compromises to be made, but always think big.
So empowering families and individuals with care needs to be able to ask for what they want and say what matters to them.
And to even think what they want in the first place, not to just accept this is what you could have. Oh, I didn't know short breaks were available. I didn't know it was possible to for my child to go to Brownies. He was not often invited on play dates. Parents would
becoming a patient representative or a user representative, and talked about being part of the diabetes pathway group. What were some of the challenges along the way? You talked a bit about how to do it, but you made it sound like if you do some of those things, you'll get in there. But I'm sure there were some challenges along the way of people wondering why they might want you there.
Well, the challenge is obviously you challenge the structure first. That's what I had to do. But before that, it was the information is not lay in terms of from our public point of view. So I then approached the structures that there, like Health Watch, like who have any local authority. So well, there's this documentation from a patient and a public point of view. How are you going to help us make it some summary of that? So it was trying to look at that was one challenge. The other challenge was very much. It's not just Kirit mystery. It's about taking the patients, our diabetes patients, and equipping them with these opportunities and say, okay, come and mentor me. I'm happy to mentor you. Right? Shadow, come to the meetings, right? And then hopefully you can take that role on, because that's the way we have to mentor. And luckily we've, in the East Midlands, we've done patient leadership programs to get that. We've done patient public events in each of our localities across the region to then get more patients to be aware. But what we did was we got all of the NHS structures and some of the third sector structures in the same room, the leads who were leads for patient public involvement in the room, and say, right, here's your opportunity, patients, public, right? This is so-and-so from the Mental Health Trust, this is so-and-so from the CCG. We produced a little directory of their names and their contact numbers, right, and their emails. Because what I was finding was, I was getting passed from pillar to pillar, right? And people in the commissioners weren't willing to give me their emails. And I just then, I said, come on, let's use your common sense. Google search, go on to, when I went to King's Fund, right, I used to see my commissioners at King's Fund. So I used to have their details anyway, because they produce some really nice attendance lists. You've got apps that you can then email them directly. So again, you have to be smart. But the biggest challenge is that some patients feel that they don't have a voice So it's about how do we ensure that we have that collective voice and bring people with us, and that's what what I've tried to do with our diabetes group is have that collective voice, and
well, that's and that is also really interesting because that chimes with what you're saying about your experience in Streatham around ICSs, is that it's very difficult to find your way in, to navigate your way around the system, and then what you've also not said directly, but by the sort of coaching and buddying and mentorship and patient leader program you put in. I think the other bit is that then when you do finally get in to that wonderful meeting you've been trying to get to, often the conversation is unintelligible because of the language that people use, the number of acronyms, and it all changes. You've just got your head around transforming care systems or sustainability and transformation partnerships, and suddenly we're into integrated care systems.
And you said right, the biggest
and
challenge.
it all sounds like gobbledygook if you're not a part of that world.
And the biggest challenge is you get in the papers the night before or the day before. So in terms of preparing yourself, it's a challenge. So that's another.
So, and this discussion, I think, is really helpful for us because we did some work which Rachel uses an awful lot around. I can't remember what it's called, Rachel, but working about how to work in partnership and really work with patients. And actually, there's more that I think we can build into that as we refresh that piece of work from this discussion. Because I think life gets more complicated in the NHS, not simpler, really. Yeah. And it does make it very hard if you want to share your experiences to help the NHS learn and improve. I'm going to ask any more questions, because I've just had one of mine that I said I was going to hold back on. Yes, please.
Yes, Fraser Syme of Syme Rose. Okay. And Cyriline, it's nice to see you again after 25 or 26 years, is it?
Oh, wow.
You were introduced by Carmel Crowley.
Oh, wow.
Anyway,
very good.
One of the things that basically I think applies to everybody, especially Cyriline, in her thing, is we're members of the Lambeth Community Connectors, and with that we're sort of going out and we're dealing with the community as and when required. But basically one of the core issues with regards to that is active listening. So I think that's something that we've got to try and push on all the authorities, whether it be clinicians, whether it be doctors, directors, NHS, or whoever. It's high time, I think, they paid a little bit more time to listen to the patient, the citizen, the person, whoever it's going to be, and actually hear what they're saying so that things can be moulded, such as the personal care, around what they want and need. Not necessarily the need first, but what they want first, so that things can be taken from there. And that applies to your situation as well.
Absolutely, and I think that's a really key message that's coming along. I don't know if anybody wants to comment back on.
Some of the one point is that some of the organisations do have these surveys. You said we did. I said, well, you didn't do it because obviously you and sometimes it's reviewing that and where the gaps are, and once you find where the gaps are, you then approach them and say, okay, well, how can we be involved in helping? Because they talk about co-production, co-design, but it's all, it's good to see that there's some good frameworks now put in place for this, but it's something that it's a lot of talk still.
Yvonne.
Yeah, I was really interested in your comment about need as opposed to want. We have lots of discussions about that in the NHS based on lots of things, not least money. And sometimes what patients want isn't necessarily what they need. So there has to be a balance in terms of giving people what they want as opposed to what they need, because sometimes it doesn't marry up. But you're absolutely right. Listening to what people need and listening to what they want and coming together to co-produce their personal care. I mean, I was particularly inspired by your story. I think it's a fantastic story, but I suspect it hasn't been as straightforward as you have made it out to be. And I suspect you're an incredibly strong and tenacious woman to push for what you're. And that's the issue. If you are strong and you are articulate and you are able to really push the system, you will get what you want eventually. If you aren't, then it becomes incredibly difficult for you to navigate your way through the system. So your point about people listening and hearing what people want from all sorts of backgrounds is absolutely key. And the thing about us being, I did smile when you said that some of the language we use is unintelligible. it's unintelligible to us as well. Half the time you're sitting in the meeting and you think, well, what does that mean? Because actually there's a kind of NHS speak, and you have to be able, you can't go in there and talk like you do to your friends, for example. There's different ways of putting yourself across. It's a very conservative organisation, the NHS, and it holds itself in check quite a lot. So if you look at some of the meetings, there's not a lot of fiery, disagreement and all the rest of it in there. It's always very staid, and you're putting your point across in a certain way. So in order to get to where you have got to, I really do take my hat off to you, because I think that you're a pretty phenomenal woman, really.
Thank you.
Yeah.
Can I just have
Go on, Cyril.
Can I just say, yes, it has been a battle. It has been a mountain to climb. We did have to go and take a tribunal case to get my son into a special school. We had to take a tribunal case to get him into a special needs college. He was out of education for a full year because they offered 3 days a week, which is not relevant to his needs, did not meet his needs. We had to explain that didn't. They settled after a full 14 months he got back into education. But, we knew what he needed and we knew what he wanted to do, and it has been a battle. Can I also add that the lgsfoundation.org.uk is an organisation I'm very particularly involved with, and it helps to signpost parents of other children with very complex epilepsy. It's a very rare syndrome. You may come across people in your lives who have epilepsy. They will not all be like Fergus. He's got one of those very rare, impossible to treat, intractable epilepsies, that it does not respond to treatment. So for other parents in that situation, life is also very difficult, and that foundation helps signpost them to other services and supports that they need. So that's important to say.
And I think this part of the discussion is really important, because it is such a difficult journey for people. Often when you're not getting the right care and treatment, you're not being listened to, and you're talking to professionals who are extremely intelligent and able and competent in their field, and challenging that is not only difficult, but actually it can be frightening at times. If they're telling you something different, you can lose faith in what you believe and worry that you're making the wrong decision. And I think that comes back to then what you were saying, Kirit, about your patient leadership programme, which I think is so important. I think often the mistake the NHS makes when it engages and involves patients in things is it just thinks, we've got that patient, we'll plonk them in this meeting. But if we don't support and develop them and help them to have confidence, to know that it is all right to disagree with a doctor or a nurse or a health service manager, and to have a different viewpoint, and how do you stand up for that viewpoint when the rest of the room is taking a very different, and as Yvonne says often, more conservative approach. So I think that's something that's really useful and for us to think about as we go forward. Is there any other questions that people want to ask? While I'm just waiting for that, I've got, if Caroline.
Sorry, Caroline here, trustees. First of all, thank you to the three speakers. I want to reiterate that. I'm just really interested about this. It sounds esoteric use of language about want and need. I think too often professionals in the NHS decide what someone needs before they've ever listened to their wants, and actually the person themselves might know what they need much better than most professionals. But I also wanted to link it back to what you were saying, Yvonne, about the way we treat staff in the NHS, and actually they don't feel listened to. I think you're very kind calling it a stage organisation. Perhaps bureaucratic, and I'm sure I'm not going to be popular for saying this, but often considered bullying organisation is not one. If you're not listened to, if you're one of the 1.4 million people not listened to, whatever you're hearing, you need to listen to people and start with that fantastic question. So going back to 2008, heaven's sake, the evidence was there already. Where do you want to get to in life? It's just such a great starting point, whether you've got cancer, diabetes, whatever sort of journey, pathway you're going on. And so I suppose the question, after all of that rambling, is how, if you're sitting there in the middle of it, I do not envy you, how do you create that change of culture in such a large organisation, such a bureaucratic organisation? That's got to be the heart of it.
It is.
Surely, And I'd love to know, I mean, Kerry, if we could get 20 million of you,
That's what you need.
20 million Cyrilines,
This is what you need.
you know, because that's, if that's the getting people to listen and change, but how do we do it? So what do we try and how do we change that?
Who wants to
Shall I
start?
kick off?
Yes, do.
Because I think it's a really, really good question. So for the length of time that I've been in the NHS, what's been important has been hitting targets and saving money. So the types of people that you employ and bring in to the NHS to do that work are a kind of individual that is very driven, very transactional, wanting to make sure the process is right, and they've had fantastic careers. Some of the chief executives and senior leaders that I know have had fantastic careers doing just that. Now we know that it isn't all about hitting targets, it's about people. And it's about making sure that the people that you have in the NHS are cared for, looked after, treated with respect and dignity. But the people that we still have at the top are people who are less transformational and more transactional. So you've got this mismatch going on, and it's like a super tanker trying to turn it round so that we're thinking much more about people. The long-term plan has at the heart of it the people plan, and I guess you have heard of the people plan, the interim people plan. And people still say, oh, here we go again, another plan and the rest of it. The good news, and this is good news, is that we've got a completely different individual leading the people plan. Her name is Prerna Izar. She is an Asian lady, beautiful woman, by the way, absolutely, but more than just that, inside and out, she gets people. And what her aim is to make sure that we in the NHS start to focus on our staff so that we can give all of our patients a better experience. So an example of that is that most of the time you have your meetings in, a Skipton House or Quarry House. She takes us out. So the 2 meetings that I've had with her so far, we went to the Homerton Hospital and we sat, and before the meeting starts, we had to meet with patients. Last week we went to UCLH. All of the team were out and about. We went to the transport, we went to outpatients, for people like me who are nurses, we know what that's like. But for people who are jobbing managers, going in and sitting with patients and talking to patients and being with somebody who's 90 years old and has been sitting waiting for transport for 4.5 hours really focuses the mind. And the fact that she is very different and is looking to do things differently, I actually have some hope for our system. The issue is getting all those other senior leaders in that place as well. And so we're hoping to have some sort of, I hope they get an epiphany or something where they really understand that this is important for our patients. And it is about what matters to you, not what's the matter. So I really applaud you for saying that. So thank you.
Can I answer as
Yes,
well?
please do, and then I'll come to it.
Sorry, I just want to say that I now work for NHS England in the personalised care team under Director James Sanderson, and there is a team of 140 people within the Strategy and Innovation Directorate across the country looking to engage with patients and develop co-production groups. And this shift in relationship diagram was co-produced by the National Strategic Co-Production Group, which is made up of people with lived experience. And they wanted to highlight the changes that are required and even the detail. You'll see just a little car picture. It was being led by the professional and you were in the back seat as the patient. Now you're co-producing your personalised care plan. You're working together. So it's the detail of each of these drawings is actually really important, and personalised care is on the agenda. It will not happen overnight. It's, it will happen. There are colleagues of mine who work across the country, nationally and regionally, to support the development of co-production groups within the regions, and hopefully this change will start to become real for people across the country. I'm only there the last 6 months, so I'm quite new.
Brilliant. But so are you saying they're actively recruiting people like you with lived experience?
With lived experience, yeah.
Brilliant.
Okay. It's the best job ever.
Excellent. Very good. Kirit.
I think my last point really is that you've got to find your allies within these organisations, right? And once you find those allies, is to connect them and keep keep not bombarding them, but keep having weekly, drop an email weekly, say I'm still here. You know, is there anything that you're engaged in that we can be involved in from a patient, and just keep doing that. But I think really for the Patient Association, I think there's a real opportunity now in terms of going forward and championing the patient voice. We've spoken. I've been a patient ambassador for the Patient Association for about 4 years, but I've been harping on about this, that we need to move outside of London, because at the moment, visibility-wise, patients don't know what the Patient Association is. So I think your strategy is going to be the key, and regionalising or being more visible outside of London will help. And finally, we've got to have the patient leader programs, or the programs that NHS Yvonne's involved in. We need to look at how can we have a co-produced patient program, align that, because okay, we do get, as patients, sometimes we get invited to the leadership programs to come and share our story, but we want a little bit more of, and sometimes these patient leadership programs we don't have access to, because sometimes they're costing too much. So you know, we don't have that. So we've got to probably, this is something that from as a Patient Association can start looking at as well, and working, because you're in the right position now. You're part of the NHS plan, you're part of the Assembly, you're part of all of these structures where, and I hope by having a seat at these tables, we will actually increase better diversity, better patient voices, and hopefully next year we'll share some more successes. So thank you.
Rachel, thank you. I think those are really important points.
Really carried, you're absolutely right, and I hope that this time next year we're going to be there with much more grassroots engagement, and you know, this live streaming is so that we can be a little bit out of London as well.
Great.
It's not the centre of the patient world. And then I think Yvonne is so right about people plan, and actually what I found with England at the moment is they're really trying to engage us as patients in the people plan, and we're seeing them again, we're seeing them next week about how to get that voice in, because it isn't just about, I think what you said at the very beginning, it's about the values of people working in the NHS, and that's what they're talking very close to me about, is actually how do we hear from patients, what are their families, obviously, what is really important when you are with a healthcare professional. So we will get quite a lot of engagement in there as well.
So thank you, Rachel. And I'm going to take one last question, because then I think we do need to draw things to a close, given our timetable.
Well, if no one else is going for it,
go for it.
I was just going to say, in relation to what Yvonne was saying, this idea of the actual experience, it's amazing how much impact that can make, because just two examples. Fraser and I were at the HEC show last week, and the guy from Wi-Fi Sparks was giving an example of how he was setting up the system. And he said the revelation for him came when he got appendicitis and he was in hospital. Then they messed things up and he was in there for quite a while because they messed up his bladder. And he now was a patient and understood these stupid systems with the phone and having to get cards, charge them up for money, and how it was just a horrible, horrible system. And then you sort of expand it further, even with our dermatology patient panel at St. George's Hospital. The clinicians don't really understand what the patient experience is from turning up, how it all works. And we've had two situations, like my very first appointment, I had 7 letters to get that appointment, 2 appointments were cancelled, then I had 2 more saying, are you still wanting to come? I haven't done anything, it's all been done by the appointment making section, which is part of outpatients, not part of the clinic. And we had a situation in one of our recent meetings, because we're actually very fortunate we have two consultants there, and they were being asked about the friends and family questionnaire by a person. And they were saying, yeah, well, we have this problem because, you know, we have the paper system and it's clipboard. And they said, well, why aren't you using the tablet? And they said, well, we don't have the tablet. And it's like, what? Well, we spent a lot of money dividing the system. Why don't you have the tablet? How can we know why we don't have the tablet? You haven't given us the tablet. And you think, does the left hand know what the right hand's doing? So money's getting spent on interesting systems, but it's not necessarily getting spread around properly. You think, and you talk about money being wasted in the NHS or NHS being short of cash, and somebody needs to be looking at where the money's being spent and how it's being spent.
So you've raised some very interesting points there about appointment systems, and I think that anybody in the room who has had to go to an outpatient appointment or of any sort will have had the same experiences as you, and there must be a way that could be done better. But that's a whole another discussion, which we haven't got time for today.
No, I'm just going to add on to that, because one of the things that we raised fairly early on in relation to this at St George's was when you have a situation that NHS England has determined that all GP surgeries must have a patient group, we said, well, why not when it comes to healthcare trust? Why shouldn't each clinical area have an obligation?
Yes.
And it was like, oh no, we're different. I'm thinking, sorry, you're the same because you're medical people dealing with patients. And the thing that's been proven to be very interesting is once they actually start engaging with patients, they start understanding what the patients are experiencing. And then it becomes a bit of a, ooh, is this really happening?
It does focus the mind, and I remember last week people were really not just upset but concerned that somebody of 90 was sitting in the chair waiting for transport for 4 hours.
Yes.
They could see it. That was the thing. The patient was right in front of them. So it wasn't like somebody on a piece of paper over here somewhere. They could actually see it, and they were moving heaven and earth to get her home. So all of these senior managers were like, well, we have to do something. We need to, even pay to give her a taxi. But that wasn't the issue. It was how the system was working, and it was broken. It wasn't working well.
Yes.
So
I was just going to say, as a final shot, one of our members
Very final.
is doing some work in oncology, and he was looking at people that weren't followed up for appointments. And it turned out this lady had received a number of letters, and she had cancer, and it was a bit of a concern. And when he did some investigation, which I believe made a phone call, it was discovered the lady's blind.
Oh.
So these letters were of no use whatsoever, but nobody apparently had thought to contact directly through a different mechanism. And it's just, there you go.
we have to do things
We
differently.
do. So I'm going to bring this to a close, but to say thank you so much. Kirit just whispered to me he had to leave to get his train, so he was very sorry to go so early. But thank you so much to all three of our panellists. The discussion has been so rich, and with our work that we're going to be doing in the coming year, and are starting now to develop our new strategy, and particularly focusing around patient experience and what matters, this has been a really good start for us. There are so many things that we can think about and things that we can engage in. So thank you so much, Yvonne, for coming.
Thank you. Thank you for inviting me. I really appreciate it. Thank you.
It's been absolutely fantastic. Thank you so much to Kirit, who came to talk to us about his experience, and I think that's been hugely helpful on how we can think about how patients can be more engaged and leaders. And thank you so much, Cyril, because you've talked again so warmly and movingly about your son, and about some of the little things that if people just thought about, they could change, that would make such a big difference and could help make that culture change for people to think about what matters to your son and to other sons. So thank you all very much. Can I ask you all to give our panellists a warm round of applause? Almost to the end. To any other business, Rachel, is there any other business that you want to bring to our attention?
Yes, so as you know, we've been on a journey for the last couple of years, and there's a survey that I think most of you have a copy of to tell us about how the AGM felt for you and what we could do better and different next year. So we'd be really grateful if you can take a few moments to complete those, so that we can just build on the feedback. And I want to add my personal thanks, because I met these two amazing people on my trips out and about to different meetings, and was like, yes, I've got my panel. Thank you.
Thank you. Brilliant. So thank you all very much, and thank you to all of you for your questions, your involvement, and for coming and joining us today. It means so much to all of us that you're all here.
Thank you.
Thank you so much. Are you going back to Derby tonight?
Yes.
Very good. But at least we're not too far. King's Cross.
Yes.